big players are among the people that, that we're talking to and that are following us. And I think we see this as a role for multiple technologies, as there often is the case, as we expand and as we see. So our initial space is in what we're calling sort of general endoscopic ultrasound. So maybe there are three layers of endoscopic ultrasound to my mind, right? The first layer is one in which perhaps you do imaging only and use the results of that imaging to draw conclusions, perhaps to send the patient along to somebody who's more experienced than you are. The second level is one in which one is taking samples, FNA, fine needle aspirates, fine needle biopsies, to obtain diagnostic material. And that's probably where most people are in the endoscopic ultrasound space these days. And that's one that's growing rather rapidly, particularly, as we see more and more personalized medicine, the need for samples, the need for genetic analysis, the ability to inject chemotherapeutic agents or biologic agents. So that would be, I think, the second level. And then the third level is the interventional kinds of things that we're doing, draining gallbladders, gastrojejunostomies, extra-luminal kinds of activities with axiostents and other devices like that. So I think those are the three levels that I see. Right now, we're most interested in the first two, although we have had experience using lumen-opposing stents with our device, and it's worked quite nicely. We see the need in terms of accessibility in the first two spaces. And so in the US, it's about cost and about the fact that fewer than 20% of general hospitals, non-academic hospitals, have endoscopic ultrasound, and fewer than 3% of surgery centers have access to this capability. So that's a huge unmet need. You go outside of the US, and the need expands exponentially, right? It's a technology that has just simply been unavailable, even as it becomes more important. And so the ability to effectively democratize EUS is, to my mind, that's the holy grail. The idea that this becomes ultimately a part of a regular endoscopic examination. And so why would you do an endoscopy on somebody for gastrointestinal symptoms, nausea, vomiting, weight loss, abdominal pain? Why would you just look at the surface, the lumen of the esophagus, stomach, and duodenum, when you could look at the surrounding structures in the mediastinum, when you could look for lymph nodes, you could look at the pancreas, gallbladder, biliary tree at the same time? Why wouldn't we embark on what we think is that transformational level, which is echoendoscopy? The idea that every endoscopy gets the maximum amount of information from putting somebody to sleep and putting a scope down. And that includes imaging optically, but it also includes imaging from an ultrasound point of view. So as I look at it, that's a space where the legacy technologies doesn't lend itself as well to, and where we can make a huge, literally transformational impact. There are 10 million upper endoscopies that get done in this country. And, I don't know if you do endoscopic ultrasound, but the patients that I see often get to me after a round of PPIs, an upper endoscopy, a regular ultrasound. They still have pain, so the PPIs are increased. Now they get a CT scan, and now they're still having discomfort. So now they end up coming for a survey diagnostic endoscopic ultrasound. Why wouldn't that be the first step in an exam if you're going to do upper endoscopy?